So we've gone over how the nervous system is laid out, how it works, the basic parts of the brain and what they do. Now we're going to get into some more pathology of it in looking at things that are going to change your ability to think or operate, your alterations in your cognitive function. You can have a stroke, you can have an accident, you can have a disease. Any of these things can affect the cerebral cortex, which means the true processing and thought mechanisms. The brainstem, which is more like your lizard brain, which is designed to keep your heart beating and keep you alive. Your spinal cord, your peripheral nerves, any of those things can be damaged. Today we're looking more at the central nervous system part of that for the most part. We'll touch on the other aspects a little bit as well. So first, to define some things that you have or can have go wrong, consciousness is your awareness. It's not whether you're awake or not. That's your state of arousal. You're either awake or you're not. You can be awake and not be conscious. You can be in a coma with your eyes open. You can't be conscious without being awake. Okay, so you can have something that happens that leaves you awake but unconscious, or you can have, but you can't be conscious but not awake. So it's not exactly one or the other here. Okay, so we have the cerebrum. That's where your consciousness has to exist, because this is where your actual thought processing occurs, especially in the prefrontal cortex, your ability to actually think and plan, your personality. These other areas allow you to send signals to move. They allow you to process inputs from your sensory nerves, from your eyes. Even the visual cortex back here has its processing centers up in this area. Below that is the cerebellum and the brainstem. There's a sort of a fibrous plate between the two called the tentorial plate. So you can have a supratentorial problem or an infratentorial problem. It's either, cortex or the structures in here, which include the reticular activating system, which decides whether you're awake or not. All of that stuff is supratentorial. Infratentorial is the lizard brain part that actually keeps you alive whether you're conscious or not. So a coma is an alteration in your awakeness or your arousal. If you're in a coma, generally speaking, especially if it's a profound coma, you're unconscious, but you may have, certain body functions are still working. You can have a coma produced by damage to the cortex, which basically puts you to sleep in a way, or you can have a brainstem damage, or you can have a separation of the two that doesn't allow them to communicate properly. Damages or suppression of the reticular activating system, which is not in the cortex, it's within the brain and around the midbrain and pons area. That's the part of the brain that determines whether you're fully awake, only partially awake, or not awake at all. So, alterations in arousal. You can be sleepy or groggy. You can have a hard time making sense or thinking clearly, or you can be essentially asleep. Some other changes, apneas. If your brain isn't processing properly the signals coming back from your body, often it's like if you're a bad driver and you go too far this way before you go back this way, or you speed up and then take your foot off and slow down, speed up instead of being able to keep a steady pace. And so post-hyperventilation apnea, Apnea means lack of breathing. So people who are in a coma will tend to, and then they stop for a while. It's kind of like sleep apnea. So they breathe fast when the signals get so powerful they override the brain damage and force them to breathe, and then they stop for a while once there's plenty of oxygen in there. Shane Stokes respirations are similar, but you never totally stop. What you do is you speed up and slow down. You speed up and you slow down. Again, there's a lag in the processing of the oxygen and carbon dioxide levels in your blood. You have pupillary changes. The pupils don't respond as they're supposed to, and we'll look at what that looks like. Oculomotor responses, your eyes can't track properly. Motor responses, that you change your posture or you respond inappropriately to stimuli, like being stuck with a pin. Vomiting, yawning, hiccups, some of these things, again, these are normally suppressed by proper feedback from your body. And if that's interrupted, then you go too far in this direction and then you do something more dramatic to balance it out. Yawning, for instance, is actually a process to get you more oxygen. So if you're going through this stuff and you are slowing down your breathing or stopping it to the point where you're becoming hypoxic, you're likely to yawn. And again, if you're in a coma, you don't know it, but the people watching you do. Here's some pupil changes, and you don't have to memorize these for this class. This is physical diagnosis, and you'll have plenty of that in your nursing or PA programs or medical school, wherever you wind up going. But your pupils can tell you a lot about what part of the brain is working or not. In A&P2 in our lab, we went into the dark room and did the pupil test, and you could see that when there was a light on it, it constricted quickly, and you take the light off and it dilates rather quickly, and it's a bilateral response. It should be equal on both sides, and it should be rather dramatic. You should be able to see it. It should be fairly quick. Well, a metabolic imbalance, so you have a severe electrolyte imbalance or something to do with thyroid or whatever. Small, reactive, and regular. In other words, they're still working, but they never dilate as much as they should. They're small, and they do react simultaneously. Problem with the diencephalon area, they're very small, but reactive. Sluggish third cranial nerve palsy from diabetes. There are third nerve palsies. So the third cranial nerve, oculomotor, this is going to have an effect on your eye movement, but it also controls pupillary response. Sluggish, dilated, and fixed, and it can be on one side because you have pairs of cranial nerves, so normally they don't both go out at exactly the same time. So what you'll have is one eye that stays sort of dilated while the other one is responding a little bit better. The midbrain, large and fixed. They won't constrict. Pontine, tiny, tiny pinpoint. You can have this from some severe drug overdoses too that affect that area of the brain. They won't dilate. They're just super fixed. Midbrain dysfunction. They're a medium size but fixed. They won't respond. And so by just doing that light test, you can get a lot of information about what part of the brain might be malfunctioning. Eye tracking is important too. And you remember we did the H and we followed around and you could see how whether they could follow your finger. And so eye tracking is important. So you can do that, and if they don't track right, that's a bad thing. Another thing you can do is ask them to look at an object and then you move their head, and their eyes should stay focused on the object. The eyes shouldn't move with the head. And this is called the doll eye phenomenon, because you know, you lay the doll down and the eyes keep looking at you, you know, if that kind of doll. And so if you have somebody that seems to be in a coma and you try to get their attention, you move their head, if their eyes stay on the target, that's a good thing. If the eyes just go wherever the head goes, that's a really bad thing. So not only your eyes should stay on the target, but both of them should stay on the target. They should stay pointed in the same direction, not one go one way and one the other. Oculovestibular reflex. This is something that they'll do on somebody who seems to be in a coma, again, to test the normal reflexes of the nerves in the head. And it sounds terrible, but you know, if the person's in a coma, they probably don't know it. But what you do is you squirt cold water in one ear, and the normal response is the eyes immediately track in that direction. If they stay straight ahead, that's bad. If one eye moves and the other one doesn't, that's bad. So if you have damage to the brain, it can come in several different flavors. We can have brain death, which in general is an overall concept. We can have total brain death, which really means you're dead, but it means that all parts of the brain are malfunctioning. Or we can have cerebral brain death, which means you can't think anymore, but you may still be kept alive by your lizard brain, by the brain stem, the midbrain, and so forth. So brain death criteria: no ocular responses. You can't get the pupils to do anything. The doll eye thing doesn't work. Squirt in the ear and the eyes stay straight ahead. That's a really bad sign. Isoelectric EEG, of course, that means isoelectric means flatline. And persistence, you know, 6 to 12 hours. So after that amount of time, if it hasn't started up again, even if you've kept their body alive on a respirator, it's unlikely to come back. Other things are musculoskeletal, that signals from a dead brain or partially dead brain that go down from the pyramidal tracts down the spinal cord and then out to the limbs are interrupted or poorly transmitted. And there are a couple of different postures. If the person is in this, it's called the decorticate posture. And the decerebral posture is arms extended down here with the hands out. It can be one side because it's bilateral. You know, it's a two-sided system. So seeing a person in these kind of postures after a motorcycle accident is a really bad sign that there's brain damage. Total brain death means no part of your brain is working. All of those things unresponsive to any of the stimuli you can produce, and the isoelectric ECG, and no spontaneous breathing. If you turn the ventilator off, they stop instantly. They don't breathe for a little while and then stop. They simply stop breathing. Cerebral death is a little different because, again, the brain stem, cerebellum, and so forth, the infratentorial stuff, can keep you theoretically alive. You can be lying there and still breathing even on your own, even if the cerebrum is essentially dead. And it means that you're in a coma. In this case, it's going to be irreversible. If the cerebrum is actually dead, then you could lie there for a long time breathing, perhaps even though the cerebrum isn't allowing you any thought processes or anything like that anymore. So you can maintain your internal homeostasis, your GI tract can more or less keep working, your heart can more or less keep beating at a decent pace. You can remain in a complete coma, or you can emerge into what's called a persistent vegetative state, where it looks like you woke up, but you're not there. You're breathing, you're lying there. And there have been, a handful of cases in history where these people have been awakened spontaneously. Obviously, a somewhat of a misdiagnosis, because you can't have a dead cerebrum that comes back to life. You can have one that is so shocked or stunned that it looks dead and may come back to life. But there are stories of people after 20 years that suddenly woke up. But persistent vegetative state means that they are not going to come back if you actually diagnose that. Minimal conscious state depends on how bad it is. This isn't all or nothing. If it's shock, if it's severely damaged but not exactly dead, the person can kind of wake up to the point where they might even be able to, grunt when you say something or move their hand in response to a question. The cerebromedulospinal disconnection, that's where I'm talking about. The cerebrum is still working. The midbrain and spinal processes are still working, but they can't communicate properly with each other. This can be temporary or it can be permanent. And what it does is it puts you in this locked-in syndrome where none of your voluntary movement signals can make it through the midbrain and brainstem area to go out, and so you're just absolutely stuck, except you can still think. You can hear people. You can't talk. You can't, usually though, you can still blink your eyes because the optic nerves are so far up and are a separate set of nerves from all of your musculoskeletal nerves, the rest of them, that people can still blink. And so they can actually communicate either with Morse code or by, say, blink 1 for yes and 2 for no kind of thing. A total locked-in syndrome is so bad that you can't even move your eyes. And then the people trying to rouse you have no idea that you're hearing what they're saying or understanding what they're saying. They just think you're in a vegetative state. So that's the real highest level of disaster. There are varying levels of alteration in your ability to process or understand information or to send out new information. So some alterations in awareness include a variety of different concepts here. Normally you can select from your available inputs. What we have is a good ability to, our reticular activating system keeps you aroused and aware, and also filters out the sound of the air conditioner, which if I can't do that, the sound of the air conditioner is going to be just as important and intrusive as what I'm trying to concentrate on. The feel of the clothes against my skin. I won't be able to differentiate which is important and which is not. So that's a problem. But normally, we can filter out the things we don't need at any one time, concentrate on the things that we do. Sensory inattentiveness, if you damage an association area, the inputs come in, but you either can't tell what they mean, or you don't even know that they mean anything. The light comes in your eyes, but you can't tell what it is you're seeing, or you don't even realize necessarily that you're seeing something. A sensory inattentiveness means, you either can't detect it even though your eyes and ears are working. This isn't blindness and deafness. The signals come in, but you can't tell that they have come in because you are not processing them. So extinction, you have no processing of information. Neglect syndrome, you actually see it. People with this, they can describe that there's a square in front of them or a triangle. You can tell that they can actually see it, but if you put it there, they won't bother to notice that it's there. It can be for just the right or left eye field. You might neglect the entire world on this side. It's coming into your eyes, but the processing area for those particular nerves isn't working, and so you're neglecting to notice that that stimuli is there. Selective attention deficit means that you can't weed out the bad stuff. ADHD and autism both have this problem in that it's hard to filter out the stuff that you shouldn't be concentrating on at the time, and instead you're trying to concentrate on everything at once. The sound of the toaster popping up sounds like an explosion to an autistic kid. So we know that there's a lot of people diagnosed, especially kids, but adults too. They usually learn to deal with it somewhat, although we've all been exposed to people who are ADHD. Used to be called attention deficit disorder, just ADH, but that hyperactivity was thrown in there too because, or ADD it used to be. Now that has the hyperactivity thrown in because there is so much response to so much. It's not just that they can't pay attention. They're paying attention to everything. And so it's a little more accurate to call it that. So they have a deficit of selective attention. They have difficulty executing plans, making plans and actually carrying them out because they get so distracted. A very short attention span because something else will intrude before they finish what they were trying to do. Deficient impulse regulation. They're responding to the wrong things all the time, and therefore their impulses seem absolutely inappropriate to what the situation is that they're dealing with. Because in their mind, they're actually dealing with something else that you're not even noticing. This is what leads to that hyperactive behavior. Children who have this have a considerable learning disability because they can't concentrate on something to pay enough attention to it. However, if you give them something that they like enough or is very interesting and stimulating, it will help them focus. And a lot of times these kids can do quite well working on something that is really cool to them. We've all heard of amnesia, can't remember. Get in a car accident, oh, I can't remember. Movies, I can't remember who I am. I can't remember the born identity. Can't remember where I came from, why I'm here. There are a couple of different levels of this. Retrograde amnesia means I can't remember something that happened before. It could be a complete retrograde. You can't remember where you were born, your name, anything. You can have a more selective type of retrograde amnesia where you were in a car accident and now 3 weeks later I'm talking to you and you certainly understand what's going on now. You even remember yesterday when the nurse came in, when you and gave you your food. You remember what you had for breakfast this morning. So but there's a chunk of time that you're missing. I don't remember anything about the day of the accident or the 5 days afterward. It happened to my brother, who was hit by an oncoming car that was driving the wrong way on the freeway at night. And he had amnesia for about a week of the period after that. So when we talked to him later, this was a period in the past that he had lost. Anterograde amnesia means I can't learn new stuff. This, it doesn't have to be that bad. If you can't remember 2 weeks of your life in the past, so what? If you can't remember your whole past, that really sucks. But anterograde amnesia is worse in that you can't make new memories. And there are a few really good examples of this where people, you talk to them and they seem kind of frantically interested in what you're saying. But as soon as you're done saying it, they don't remember this new conversation. Alzheimer's patients will get that, and they'll tell a story and they'll immediately tell it again and tell it again and tell it again. I had an older friend with Alzheimer, and sometimes if you're willing to sit with him long enough, you would hear exactly the same story a dozen times. As soon as we get to the end, start over again, and start over again. He had memories of the distant past. Those with Alzheimer patients tend to hang in there, and so these people, they really enjoy it if you come in and play music from the 40s and 50s, because those are things that are still in there. But if you ask them, 10 minutes later, what song was just played, they won't remember, and they might not even remember that they just had music from the 40s and 50s, because they can't create new memories anymore. You can have an imaging processing or a sound processing problem where you actually see the image, but you can't tell what it is. I don't recognize my wife's face. I can't process this in a way that puts it in a memory bank so that I know my wife is here. The person will show up with the demented patient, and they'll say, either I don't know who you are, or you haven't come and seen me in years, and they were just there yesterday. I'm going to talk about a couple of diseases that kind of manifest that way. A few words about seizures. A seizure doesn't have to include convulsions. We think of seizures as people doing this, but in fact a seizure, they can be just absolutely still while their brain is seizing. It's an explosion of electrical activity in the brain that is overwhelming enough that it blocks out their ability to actually do stuff for a certain period of time. And often they don't remember that it happened because it puts them into a semi-conscious or unconscious state. Alteration of brain function, disorderly discharge of neurons. And there are a lot of different things that go along with this. Some of them are autonomic. A lot of them do turn out to be motor. In other words, it causes thrashing about or rigidity. And if it does, then you not only have a seizure, but you have a convulsion. There are different kinds of convulsive actions. Tonic means you're stiff and frozen in place. Clonic means you relax and contract, so you have a tendency to jerk. Can be caused by brain tumors, strokes. It can biochemical disorders. It can be caused by drug abuse. head trauma, falling off a skateboard. And epilepsy, we always think of that as being a diagnosis. Someone who's epileptic has seizures and convulsions for no reason. That's all epilepsy is. It's a person who is undergoing regular seizures and convulsions, and there's none of these other reasons why it could happen. So it's kind of a default thing that you go to as your diagnosis. You can have a partial seizure where maybe just your hand does this, but a generalized seizure means it happens to the whole body. Absent before it happens. Myoclonic would be jerking around, muscle jerking. A tonic phase, stiffening. Clonic, totally clonic, just jerking again. And then the post-ictal stupor. The ictal phase is the seizure itself. So you can have a pre-ictal aura, where you're about to go into a seizure. You can have the ictal phase, and then the post-ictal phase is stupor, where you just lie there and kind of recover and wake up. Epilepsy usually follows a pattern of this sort. You have a prodrome period where you start feeling bad, you start feeling anxious and depressed and worried, and you know that within a couple of days one of these seizures is likely to come on. There's an aura, pre-ictal aura, that is actually sparkling lights. It's glowing rings around everything you look at. And this phase that happens for a few minutes would probably give you time to go lie down so you don't fall down when you have the convulsion, have the seizure. A tonic phase, a clonic phase, and then the post-ictal relaxation afterward. When I was teaching at Georgia State, I was teaching for quite a while courses that taught all the physical education majors how to teach 18 different sports, so they could teach anything that they ever were asked to teach. Well, that was cool, and we were, I was teaching them how to teach tennis, and we were out, hitting the ball around and stuff, and one of my best students, I saw him, he suddenly put his racket down, lay down, and next thing I know, he's having a seizure. And I'm going, oh my God, and I run over there, and about the time I get there, he kind of wakes up, gets right back and picks up the racket and is ready to go. And I said, no, what happened? He said, well, I rolled my ankle slightly, and he said, I have a really funny connection somewhere that if I ever roll my ankle, even that tiniest bit, I go into a seizure. I said, okay, well, no more tennis for you today. We're going to go into the clinic afterward and see if we can figure out what's going on here. And so after the class, we went into the school clinic, and he tells the doctor this, and the doctor says, wow, oh, how interesting. And he takes his ankle and does this, and the guy went into a seizure again. Turned out he was one of my best students. I made him wear an ankle brace, and he was fine. It never happened again during class. Processing of data, in other words, understanding what you're looking at, understanding what you're hearing, understanding language, being able to project language, can be altered with a brain tumor, with a stroke. I mean, you've heard people with a stroke trying to talk. Brain damage from a motorcycle accident. To know, G-N-O, is to mean to know something. Okay, so that's actually the medical term for knowledge. And so, Agnosia means a condition with no knowledge or no understanding. And in this case, it's the inability to know what you're seeing or what's around you. People have had this agnosia problem and have actually managed to function reasonably well through a lot of adaptation, but they would look at that desk and think it's a unicycle. They would look at the skeleton over there and think it's an oak tree. You know, the disconnect between, they could see it perfectly well, but they couldn't tell what it was because there was a disconnect in their knowledge base. Tactile, visual, auditory, you might not be able to tell what you're hearing or what you're touching. You put your hand in your pocket and you've got a coin in there, but you think it's a rattlesnake. Phasia means speech. Dysphasia means difficulty with speech processing. You have a hard time understanding what people are saying, or you have a hard time making yourself understood. You can do it, but it's a struggle. Aphasia means you can't process speech at all. If your speech processing centers are so damaged, you will hear the sounds, but you can't tell what they mean. You might even know they are words, but you can't tell what words they are, and or can't project them the same way. The centers aren't identical, so there are times when somebody can speak, but it's hard for them to put things together because they can't tell what they're saying because it's coming back through their ears. So their speech patterns are kind of gobbledygook, or what they hear coming in is just blah, 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 blah. An acute confusional state means that suddenly, right now, I can't tell what's going on. Delirium is this. Now, if this lasts forever, it becomes dementia. You know, if you can't ever tell what's going on, there's that. But delirium happens if somebody they've drunk way too much, they've done a major drug overdose, they have a really high fever. When I was a kid, my sister got a fever of like 105 or something, and she was delirious. She thought men were trying to cut her with glass. And she couldn't get that out of her mind, and, you know, we're all standing around her telling her she's safe, and yet she was delirious until the fever came back down. Hyperkinetic, excessive movement. Hypokinetic means you're just lying there unable to figure out what the heck's going on. Dementia is like delirium forever. Dementia is a progressive set of lack of understanding problems. Loss of orientation, people wander off and can't find their way back. They can't remember stuff. Often they can remember things from way, way in the past, but they can't remember if they even went to breakfast this morning. They have a hard time speaking, poor judgment, and delirium can be caused by plain old senile dementia, which is called that because it's an old person that doesn't have anything else really wrong with them, or Alzheimer. Alzheimer is the most common dementia-causing condition. It's actually a very common problem now. And it wasn't a problem really in 1920 because people only lived to be 50 years old. And most people don't get Alzheimer's. Every once in a while you'd have an early onset and somebody would become demented and they would put them in an institution. They didn't know what it was and they lost it, and, you know, too bad. But now, since people are living long enough for these conditions to manifest more, we have more and more people with it. Familial means you're born with a genetic predisposition to this. And we'll talk about, you know, some of the possibilities there, but it's mainly a degeneration of neurological tissue and a building up of plaques that interfere with the electrical signals moving back and forth. Signals. A mutation for encoding the amyloid precursor protein. Amyloid protein plaques are what show up under an MRI or something if you have Alzheimer. If you have this hereditary predisposition for it. Other proteins, the inability to control how much you're making or to get rid of it. Loss of acetylcholine transferase in the ability to use acetylcholine in your brain as a neurotransmitter. So these are theories. They don't know exactly yet, but there's a new one that has kind of come up that is, it's really interesting, and that is our immune system, when it produces the inflammatory response to any minor damage. Minor, we never even know it happens. More major, it happens, it swells up, it hurts, but it goes away. But what our immune system does is part of the repair process, the creation of this granulation tissue and stuff. It produces these amyloid proteins in there as part of the structure. And as the healing process occurs, your own monocytes and cleaning macrophages come in and they get rid of all of the stuff that you don't need anymore, including the amyloid proteins that were being made. Well, your brain, like the rest of your body, is always having minor little inflammations. It's just your body has to constantly keep working to maintain homeostasis. Creates the amyloid proteins, and your immune system, for some reason, is faulty and doesn't clean them up. This seems to be a good argument for the fact that inflammation in general leads toward Alzheimer, and that taking anti-inflammatories like ibuprofen seems to have at least some protective effect against developing Alzheimer. So if you keep the inflammation down in somebody who would make too many plaques and not be able to clean them up, they won't make as many plaques in the first place, theoretically. I don't know how they will use this knowledge to cure it. Maybe they can genetically engineer a better cleaning part of your immune system. Maybe they can give people whose mother and father both died of Alzheimer, anti-inflammatories for their whole life. I don't know. But anyway, it's an interesting concept. Neurofibrillary tangles, these are within the neurons themselves, in the cell body. The microfilaments and tubules and things in there overgrow and become tangled up and block that nerve's ability to actually fire and work properly. Senile plaques, the buildup of amyloid proteins, and the same thing, forgetfulness, confusion, and so forth. And Alzheimer, almost without exception, progresses and progresses until the person dies. The brain actually atrophies and gets so it doesn't work, and you can't live without a brain. So it's not just that they forget to eat, although that's a part of it. Toward the end of these serious dementias, the people can't take care of themselves at all anymore, and unless you put a stomach tube in, which by then most people don't do because the person doesn't know who they are anyway, there's no way to keep them alive. But actually, the brain malfunctions to the point where it often results in death. Diagnosis of Alzheimer is made by ruling out other causes. There can be other reasons for dementia, such as a bunch of mini strokes. My oldest aunt lived to be 105, but for the last 10 years she didn't know who anybody was. She'd had a whole bunch of mini strokes, and they finally caught up with her until she couldn't process information anymore. Healthy brain, Alzheimer brain. More tissue, narrow sulci. Here, the sulci are really wide. There's less tissue. Here it shows it here. The ventricle gets big. The various openings in sulci get really deep because there's just less brain tissue in the Alzheimer brain. Here we have the normal neurons. Here we have the Alzheimer brain neurons with the neurofibrillary tangles inside filling up the cell body and the building up of the amyloid plaques. There's another related disease called Lewy body dementia, where you build up protein plaques in the brain. It doesn't cause the neurofibrillary tangles and the decrease in brain size as exactly the same as Alzheimer. So when these show up, and that is the main finding, it's simply called Lewy body dementia because somebody named Lewy discovered them. You can have Lewy bodies in Alzheimer. So Alzheimer can include all these other things and these guys, or you can have just Lewy body dementia. Robin Williams, who committed suicide, had Lewy body dementia. And nobody ever said it for sure, but the idea is that Lewy body dementia actually progresses faster than Alzheimer. And he felt that he was losing it. He knew that he had no future, and he didn't want to face that. And so that's, a pretty dramatic outcome. What about increased intracranial pressure? Why would that increase? Well, it's because you got more stuff in there. You can have a tumor. You can have a bleeding stroke that is increasing in size. You can have swelling of the brain from bashing your head on the ground when you fall off your bike. You can have a filling up of the ventricles with extra fluid because you're making too much or not getting rid of it quick enough and swell those ventricles up. And because it's inside a hard shell, it's got nowhere to go. And so after a little bit of give, the pressure goes up really fast. And the pressure can get high enough that it blocks off the blood flow to the brain tissue, and you go into seizures, you go into a coma, and you die. Stage 1. An increase in volume by just a few % is tolerable. And as soon as you reach that threshold, the pressure starts going up really fast. And so you can send a probe in there, you can measure the pressure, intracranial pressure monitor, the oxygen, and you can also, here's a ventriculostomy. A stomy is an artificial opening. So here you're allowing fluid to go out to relieve the pressure of perhaps a swelling brain after an accident. And if you have enough increase in pressure, your brain is going to have to try to escape somewhere. So it will either try to squeeze down through the foramen magnum, or if the pressure's in the front, it'll push the brain back. If the pressure's in the back, push the brain forward. So you can have an infratentorial herniation, which is the lower part of the brain being pushed downward through the foramen magnum along with your spinal cord. A supratentorial normally is the front being pushed toward the back into the posterior regions of the skull. Here's an infratentorial. This part of the cerebellum is getting shoved down, and this medulla oblongata is moving down too. Here's the foramen magnum. You're not supposed to have anything down there but spinal cord. And if part of the brain starts getting gushed down through there, you're probably going to die. The general processes of causing increased brain case volume involve some sort of edema, an accumulation of fluid in there. Now, it could be just a growing tumor by itself. That's not edema. But anything that happens to your brain through a stroke or through damage, accident or something, will cause one of these things likely to happen. Vasogenic, blood vessel damage that causes leakage of fluid. Trauma, bleeding in the brain. Subdural hematoma, grows and grows and grows. So vascular damage. Cytotoxic, some drugs will cause bleed outs, or not even bleed outs, but cause the blood vessels to so discontinuize their membranes that fluids can go through them out into the brain, out into the interstitial fluid. Ischemic, if you have a stroke and it damages or, damage to a blood vessel that causes a lack of oxygen to get to some of the brain cells, you slow down the ATP pumps, sodium stays inside the cell, it sucks fluid inside the cell, and the cells swell up. Interstitial, if you just have high pressure in the blood vessels, you'll filter too much compared to absorption, and the interstitial fluid will start to increase its volume of fluid in it. And high altitude cerebral edema kind of incorporates a couple of these things, because at high altitude your oxygen level drops, and so your brain blood vessels dilate like mad, trying to get enough oxygen into the brain cells. Well, the dilation causes increased pressure inside the capillary beds, and they start leaking out, and you get cerebral edema that can be lethal. People climbing Mount Everest die all the time from cerebral edema or from pulmonary edema, because all the blood vessels there constrict, and that causes a backing up and an increase in pressure that causes fluid to escape into the alveoli. So dilation here, constriction here, but both things cause pressure imbalances and wind up causing edema and sometimes death. Here's edema. This is just water in pockets around in the brain tissue. Intracellular lakes. Hydrocephalus means water on the brain inside the ventricles. Those ventricles are making cerebrospinal fluid all the time, and it has a pathway. It goes around the skull, and it goes down the spinal cord, and it gets reabsorbed by the arachnoid villi, sticking down in there. And if everything's in balance, the pressure stays right, the fluid is produced but then absorbed at the same rate, and life is good. But if you either have a problem that causes you to make too much fluid, or some reason that you can't reabsorb it, the amount of fluid in there will increase and cause usually an increase in intracranial pressure. Now, you can have ventricles that get too big because you have Alzheimer and you just have less brain, and so there's just more room for fluid, and that's called normal pressure hydrocephalus. You have too much water in there, but the pressure hasn't gone up. But with any kind of damage that causes the fluid volume to increase, in a normal-sized brain, the pressure will go up too. In babies, hydrocephalus results in a giant swelling of the head because the skull bones aren't attached together yet. In a way, that's good because the pressure doesn't go high enough necessarily to kill the brain until you can do something about it. If it gets this far along, this child will probably have brain damage. But if they do something, the child may survive. They can reduce the fluid just by a hole in the skull, or they can try to increase drains. If the drains are blocked and the fluid can't get out, they can put some artificial drains in perhaps. Here's a normal pressure hydrocephalus. The head's the right size. It looks like, you have, this is probably Alzheimer's or something like that, where the ventricles are just huge. A lot of water in there, not much brain. Must be a politician. And a few minutes on neuromuscular function alterations that are not specific to cognitive abilities. Somebody with ALS, Lou Gehrig's disease, for instance, like Cawthon, who is one of the smartest men in the world, don't affect your cognitive ability, but they affect everything else. Hawking, not Cawthon. Cawthon was a jockey, and I just watched the Preakness on Saturday. Okay, a couple of different conditions that affect your ability to move. Hypotonia, a lack of ability to use your muscles. Hypertonia, spasticity, tremors. Okay, these are imbalances in your motor activity mechanisms. Hypotonia, it can happen when you have a degenerating, demyelinating disease and you get so that you can't move. Babies are sometimes born with hypotonia and they can't suck on the nipple or on a baby bottle properly. Hypertonia, there are several different kinds. Dystonia means improper muscle tone, rigidity, spasticity. These are different level, different types of hypertonia, but we're going to kind of talk about the conditions that cause these. Alterations in your ability to move usually involve either a hypertonia, spasticity, or tremor, or something like with Parkinson's disease or cerebral palsy. Paresis means you have a partial paralysis. Paralysis means total inability to send neural signals to the hand. So somebody with paresis may have damaged some nerves, but they can still do something. And paralysis, they can't even move the hand at all. They're divided into upper and lower neuron syndromes. Upper neurons are the ones that start at your cortex and send the signals down a certain distance, where they have to synapse with a lower motor neuron that takes the signal out. So upper motor neuron problems come from the brain and the brain stem. Lower motor neurons somewhere in the spinal cord or outside the synapses going out to the target tissue. Upper motor neuron syndromes can include, there are some lower motor neuron things that can have these too, but hemiparesis or hemiplegia means one side. So if I have a stroke over here, I'm going to have problems over here, generally speaking. Now, if it's high enough, if I have a stroke here, this side of my face may sag, but I may be paralyzed over here because this is before they cross over and this is after. So hemi means one side is affected. Diplegia means both. So if you have a problem that causes both sides of your face to sag, that's a diplegia or diparesis. Paraparesis or paraplegia means just your legs. So a paraplegic is in a wheelchair, but they can play wheelchair basketball and stuff. Quadriplegia or quadriparesis means both arms and both legs are affected. Knew a guy who was in a car with a friend who was driving drunk and hit a telephone pole, hit his forehead on the dome light. He was in the back seat as he was slammed forward and snapped his neck, and it damaged his spinal cord but didn't completely sever it. And he was in a wheelchair, but he could move his legs some. He could move his hands around a little bit. He could still write very carefully. So it was a quadriparesis, actually, not a quadriplegia, not quite as bad. Pyramidal motor syndromes, those are the main signals coming from that precentral gyrus. The corticospinal tracts going down to go out to your skeletal muscle. And spinal shock is what happens when you're in an accident. You've smashed it, you've stunned it, or you've severed it. Different degrees of difficulty you're going to have below that point from then on. Upper motor neuron problems, some of them going quite a ways before they go out, others stopping here and going out. So there's some overlap between upper motor and lower motor. But if I cut this nerve down here, it's not going to affect anything up here. But if I cut up here, it's going to affect everything below it. So, but the upper motor function, lower motor function, some of them including Lou Gehrig's disease, amyotropic. It means no muscle growth. Amyotropic lateral sclerosis, or ALS, is upper and lower motor nerves are involved with that. So it really affects all of your motor function, including, if you have seen Hawking in one of his TV interviews or something, he not only can't move his body, he can't speak. He can barely move his eyes. So he has created a computer thing that speaks for him. Upper motor neurons from the motor cortex at the precentral gyrus and going down to the point, they're going to cross over. Some of them synapse first, others cross over and go down a long way before they synapse, but they're the first order of neurons. The lower order neurons then take that synaptic signal and take it to the target tissue. Lower motor neurons are mostly paralysis of a limb, of a hand, of an arm, of the legs. Hyporeflexia means you don't have enough motor reflexes. So even if you have signals going to your feet, you can't walk properly because your proprioceptors are not able to determine how hard you're pushing and tell you how hard to push back so you can keep walking. So hyporeflexia means not enough. Areflexia means not at all. And fibrillation of the muscles. If they're getting improper or insufficient signals, the muscles will sometimes just quiver. Hyporeflexia, hit the knee, motor spindle fibers don't send the signal back properly, it doesn't send a signal out properly, and your leg doesn't kick out. Lower motor neurons, here's a couple of Again, no muscle growth or development syndromes. Poliomyelitis, a huge problem in the early part of the 20th century where people, kids were getting polio. I knew a couple of kids. Everybody knew people when I was growing up in the 60s that had polio. And they couldn't send the signals down to their legs. They couldn't walk at all, or they walked with big braces all over their legs. And it was really an awful thing until polio vaccines came along. And of course, Franklin Delano Roosevelt had polio. And it was in a wheelchair, even though he would never allow himself to be photographed as president in the wheelchair. He would manage to stand up or get somebody to help him stand up, and he would hold on to the podium and make his speeches. Nuclear palsies. Nuclei are little centers in your brain and brainstem that send out signals. And if you have damage to those, protein plaques, damage from car accident or whatever, a palsy is an inability to get the right signals. You can have a palsy that causes your face not to work right. Guillain-Barré, we'll spend a little more time with this guy. Herpes virus, which, the herpes virus that causes shingles and stuff hides in nerves. And when it comes out, it inflames those nerves. Muscular atrophy. Bulbar palsies. These are cranial nerve and some spinal nerve palsies caused by lesions. A lesion can be something that's added on, or it can be a deterioration of the nerves. ALS, Lou Gehrig disease, is a major creator of bulbar palsies. And the bulbar palsies will cause problems before the ALS may even be diagnosed. The person's sound of their voice changes. They get a little bit harder and harder to form words. And then it progresses more and more beyond that. Dystonia means an improper tone of the muscles with various palsies. Cerebral palsy. Kids have a hard time straightening their hands out. They may have a hard time walking. Dyskinesias mean, kinesiology is movement. So a dyskinesia is an improper movement. It can be a tremor. It can be somebody that can't stop throwing their arms around. It can be tongue thrusting and smacking lips. Old people that are going into dementia sometimes get into the tongue thrusting, hard eye squinting, facial grimacing type things that they can't control. Chorea comes from the same term as choreograph. It means dance. A choreograph is a dance graph, what you're going to do. Chorea is a condition where people can't stop moving. Paroxysmal just means they suddenly come on and then they go away again. And tardive dyskinesia is this rolling of the eyes, squinting of the eyes, tongue thrusting, often brought on by some of the more powerful antipsychotic drugs being used excessively for too long. Now, it's hard to say if it gave the person a decent life for 10 years because they had their antipsychotics and then they get tardive dyskinesia, what was better? Should they have given up those 10 years so they wouldn't have to go through this? But, it's a pretty grim situation. Huntington disease is also known as chorea. Chorea, the can't stop moving disease, can't stop yourself. Now there's some of that in some other diseases, such as Parkinson. You've probably seen Michael J. Fox, where there's times that when his condition is completely controlled, he's done a fabulous job of controlling Parkinson, which came on very early for him and which he's had for, I don't know, 30 years now. I remember when he was first diagnosed with it, and he's still managing to be on TV. But sometimes there's excess movement. It's hard to stop the little bit of extra movement, no matter how hard you try. True Huntington disease, though, was called chorea because the people were dancing all the time, inadvertently. Autosomal dominant hereditary degenerative disorder. Okay, so if you get even one gene, like if your parents were both recessive, or anyway, if you get it, you got it. I'm sorry. Autosomal dominant, if you get even one gene, you're going to have this. It's going to express, and it's going to be progressive. One of the problem is the decrease of the basal ganglia inside the brain that controls movement, some of the same areas that are damaged through Parkinson's, and also degeneration of the frontal cortex, the frontal lobe, and a depletion of your inhibitory neurotransmitter. Remember, GABA and glycine are inhibitory neurotransmitters in your brain. They keep your brain from overfiring. If you don't have enough of that, the parts of your brain affected are going to overfire. Decreased motion, hypokinesia, means you can't move. It can be simply paralysis. It can be muscle degeneration. It can be nerve degeneration. Decreased movement is hypokinesia. Akinesia, not enough. Bradykinesia means you can't move fast anymore. Or the movements are inappropriate. You're trying to do something and your arm is going where you don't want it to. Parkinson, and you'll hear me every once in a while, I'll say Parkinson's or Alzheimer's, even though we don't put the apostrophe S on the end anymore. Sorry about that. Trying to get over old habits. Parkinson, degeneration of that same basal ganglia, and an inability to produce or respond to dopamine, which is a controlling neurotransmitter in the basal ganglia. And so what you have, yes, you have tremor. This is what we think of with Parkinson. Rigidity, the muscles get really tight, and that's part of the tremor. Bradykinesia, slow movement, slow speech patterns even. Postural disturbances. They get kind of hunched over and difficulty simply straightening up and relaxing. Eventually, cognitive problems happen. They've gotten much better at controlling it now. You know, it used to be, again, when I was growing up, if you had Parkinson, you just got worse and that was it. Now, there's, a lot of improvements being made on their abilities to treat and control some of these things. Secondary Parkinsonism is being punch drunk. They used to call it punch drunk for boxers. They would get hit in the head so many times. Muhammad Ali, secondary Parkinsonism. Parkinsonian syndrome You know, it sounds better than saying they have Parkinson's. Well, they don't have the degeneration caused by the hereditary disease. They just got hit in the head too many times. Football players now are having more and more of that. Older football players, they're developing other kinds of dementia too, which is kind of related to Alzheimer with the building up of plaques inside the brain, but also the secondary Parkinsonism. And Muhammad Ali got to the point where he could barely walk, barely talk, barely do anything. Parkinson, stoop posture. Sometimes the hands are kind of curled back. Looking at posture, this guy's okay. He's just trying to fake it for us. You know, sway back. I guess, you know, it means leaning backward, but it's more of a upper back thing here, whereas lumbar lordosis is the lower back L shape here. Kyphosis, older people get, it's the hunchback. Forward head, we've seen people who couldn't straighten their neck back up. Good posture. That's too good. I can't even stand that straight. So these various postures will manifest in people with different problems. We're going to see several of these with musculoskeletal, especially skeletal problems, producing a lordosis or a kyphosis or a scoliosis or something. But some of these type postures, especially kyphosis and forward head, happen with old age in general, where you have a deterioration of the vertebrae and of the vertebral discs, and Parkinson, senile posture, bent forward, head forward, kind of rounded back. Doesn't happen to everybody. It happens to a lot of people, though. So dystonic postures, we've talked about decorticate and decerebate. If you have brain damage, the other postures are more likely due to something like ALS, Parkinson, cerebral palsy, or musculoskeletal disorders. Disorders of gait that often come with disorders of posture, but some are more specific to a condition. A spastic gait, you know, people with cerebral palsy or who have had a bad stroke, they're able to walk, but it's difficult to do. We've seen people probably with the scissors gait, which is also probably an upper motor disturbance, might be cerebral palsy. A cerebellar gait, your cerebellum is your proprioceptor center. So cerebellar problems mean that it's hard to maintain your balance, and it's more of a stagger. And then a senile gait, which is somewhat like a Parkinsonian gait, which is kind of shuffling and bent forward. Disorders of expression can come with inputs or outputs of language or body language too. You might over-express your facial expressions or under-express, or you might just not be able to project your speech appropriately. We have the Wernicke area, which is the area back here which processes speech. Damage to that area will make speech understanding or projecting very difficult. The premotor area helps you decide specifically what movements you're going to send out of the motor cortex. You know what a mime does? quietly making facial expressions. Hypermenesis, excessive facial expressions. Tardive dyskinesia, of course, would be one example of that, but other people have a hard time controlling facial expressions. Hypomimesis, it might be because you actually have no expression, or because you are feeling things perfectly well, you simply can't put them onto your face. A dyspraxia is a difficulty executing a planned motion. So there are instances where people, as the closer they get to something, the harder it is for them to get themselves to touch it. It's called an intention deficit. Intention deficit, hard to pick up a glass of water. Parkinson's disease, it not only makes it hard to walk, but it makes it hard to start. You can't get yourself to start, and then you can't get yourself to stop. So the intention, the planned activity, is hard to make happen. Difficulty executing the planned movement. This is, again, you have a dyspraxia. If you don't have these guys, but you still can't do it properly, you have a dyspraxia. Enough. On to the next one.